Hey there, it's Dr. Guerrero with your week 4 pathophysiology guidance video. Being that it's week 4, that means next week is week 5, chronologically speaking, which means it's the week of midterm. So next week, there's no new content. This is our last week of content. Then you have midterm, and then we start content back again, week 6. So I have spoken during the open group setting to let you know that I will be opening quizzes 1 through 3, the past quizzes, so that you can review your answers, but they are only going to be open until Tuesday night at 11:59 p.m. The only reason a quiz will not be accessible to you if you go to try to look at it is because not everyone has taken it. So everyone has taken week 1 and week 2. I'm still waiting on a couple to take week 3, but as soon as it's made available, that last submission is made, I will make week 3 also available for your review. I will be cutting them off on Tuesday night at 11:59. You will also get a remind message from me that tells you, hey, don't forget to check these, because I will not be able to reopen them for you. Okay, but you are welcome to look through them. You can write down questions and the responses so that you can start studying content. You do have to have the Respondus Lockdown browser engaged while you're reviewing the quizzes. So just please know that the passwords are still in the announcement so that you can access them. It's not just open to where you can screen flip and copy and paste. That's just not an option, but I did want to give you the opportunity to look over those quizzes, excuse me, so you can see what you got wrong. Okay. And again, those will close down on Tuesday night at 11:59 p.m. So week 4, we are looking at the respiratory system and then kind of respiratory renal at the end. So chapter 22 is obstructive pulmonary disorders. Chapter 23 is restrictive pulmonary disorders. Then we have fluid and electrolyte imbalances, homeostasis, and then acid-base homeostasis and imbalances. So I want to start us off with chapter 22, which is obstructive pulmonary disorders. Let the word obstructive have a solid meaning to you when you review this content. Obstructive means that there's something physically in the way. There's some type of something that is obstructing the respiratory passageway. Okay, so know that there's some physical obstruction. And I say that because when we get to restrictive, it's different and people tend to try to get them mixed up. So on the obstructive pulmonary disorders, what are all obstructive pulmonary disorders characterized by? Make sure you're familiar with the difference between extrinsic versus intrinsic asthma. Asthma characteristics, I'm looking for 3 specific things, all right? The allergic form of asthma, signs and symptoms, so SNS is signs and symptoms. Acute asthma attack, signs and symptoms. What are the signs and symptoms of a patient experiencing an acute asthma attack? What is the specific name of the life-threatening form of asthma? You definitely need to know that, and of course, the signs and symptoms that go along with that. What causes someone with COPD? Chronic obstructive. Okay, anyways, to have a barrel chest. I'm looking for that cause, what leads to that. So make sure you're familiar with that. Chronic bronchitis, signs and symptoms. Coronary effects of chronic bronchitis. So remember that coronary is the vessels of the heart. So what are the impacts of chronic bronchitis on the coronary vessels? What's the most common cause of emphysema? Tuberculosis. So TB is tuberculosis. The causes, the risk factors, findings that are unique to tuberculosis only that could help with diagnosis. Bacterial versus viral pneumonia, signs and symptoms. Kind of just generally speaking, especially those of you in clinical practice or experience with clinical experience, when something is bacterial in nature, there tends to be some type of production versus being viral in nature where it's kind of dry. So making sure you know the difference between a bacterial and viral pneumonia infection. Review the etiology, pathogenesis, clinical manifestations, and treatment of bronchitis. Oh my goodness. I just got my new retainer installed, so I'm tripping over my word. Bronchitis. they're listed right here, but we're bronchio, okay, tells you that we're dealing with the smaller bronchioles and the smaller passageways into the lungs. Cystic fibrosis, so TIASIS versus itis. Okay, so making sure on the first two, the bronchial, for whatever reason, I can't say, making sure you understand the difference between the ASIS and the itis. Okay, cystic fibrosis, acute tracheobronchial, and it's going to be more than likely a shift. So make sure when you're looking at that, that's usually how it's described. And then croup. All right, chapter 23, restrictive pulmonary disorders. Restrictive is different than obstructive. Obstructive means that there's something in the way. Restrictive means that there's something stopping it. Not necessarily something in the way. It could be some external factor like pressure. It could be your posture. Your posture makes your respiration restrictive. So if you slouch, your lungs are only so compliant. If you have some type of back disorder, scoliosis, bone deformations, something along those lines, that can also be restrictive. If you have some type of effusion, like pleural effusion, that puts pressure on your lungs. So restrictive is different than obstructive, where there's something physically in the way. So there's something restricting the compliance of the lungs. And compliance from anatomy and physiology is how much the lungs can give and take. So what is a restrictive pulmonary disorder? Types of restrictive pulmonary disorders. Tension pneumothorax. Okay, first of all, you have to know what pneumothorax is, and then understand the tension form of pneumothorax, signs and symptoms. Pleural effusion, and I just mentioned this a second ago. Effusion would be the collection of the fluid within the pleural space. So what is that doing to the lungs? Signs and symptoms. Acute respiratory distress syndrome. Causes of hypersensitivity pneumonitis. There is a box in the book that you can kind of reference there. Interstitial lung disease. So remember, interstitial means in between from anatomy and physiology. So interstitial lung disease. How does that, first of all, what is that? And what are some signs and symptoms? Sarcoidosis. Good grief. Anyways, I hope you're getting a small smile out of my Monday morning stuttering. Common characteristics. So understanding that the relationship with the respiratory system, obviously restrictive. Review the etiology, pathogenesis, clinical manifestations, diagnosis, and treatment of. Notice how I have these divided. Pleural space disorders. So remember, pleural space is the pleura, the serous membrane around the lungs. And I've already mentioned pneumothorax and pleural effusion. So if you've already answered that earlier, just create a chart, just transfer that information if that works for you. But then I also have it divided up as restriction based on chest wall deformities. So not deformities in the lungs, but in the chest or the thoracic cage itself. So kyphoscoliosis, ankylosing spondylitis, and flail-chested. Okay. And also, yes, still disorders divided up further. So lung parenchymal disorders. So parenchyma are cells, like stem cells. Not necessarily mesenchymal, so they're more defined. So they've already committed as lung cells, but diffuse interstitial lung disease. So that's going to tie back into interstitial lung disease up here. Hypersensitivity pneumonitis. I've already mentioned that earlier. So you know that these diseases are super important, especially if I brought them up twice. Occupational lung disease. So people are getting lung disease based on their job. What are some examples of that? Atelectic disorders. So first of all, understanding what atelectasis is, and then the two types of atelectic disorders, acute adult respiratory distress syndrome, and then infant respiratory distress syndrome. Infant respiratory distress syndrome, I put it in parentheses. If you had me for anatomy and physiology, we talked about that the type 2 cells within the lungs produce a fluid called surfactant. It has a dishwasher soap, like a Dawn dish soap, and water consistency. And its purpose is to lubricate the type 1 cells, which are the alveoli, so that as they are moving back and forth, they don't dry out and crack. So surfactant has a really important role in the development of the respiratory system. And this also ties into when a child's birth date is determined, when they're physically born, when labor is onset. But if babies are born premature, their type 2 cells have not fully developed and are not capable of producing surfactant. So these individual babies come into the world with the inability to produce the surfactant that lubricates the alveoli. And so it labors and distresses their breathing. First of all, understand what that is, understand what causes it, which I just kind of explained. And then how do we treat that? Okay. All right, 24. This is where we get into the electrolyte imbalances. So let me just tell you, this portion of the quiz and the content is broken up into these elements here. And if I were you, I think the best way to tackle this would probably be a chart. I'm sure you're tired of hearing make a chart from me, but it's just a way of organizing the information. So hypo and hyperkalemia. Okay, and if it's kalemia, hopefully you know that that's not, or you hope, I'm not going to tell you what it's not, that way you don't get confused, but kalemia would be associated with potassium. Calcemia, hyper and hypocalcemia, that's calcium, so that's straightforward. Hypo and hypermagnesia, magnesium, okay? Hypo and hyperphosphatemia, phosphate, okay? Hypo and hypernatremia, which is sodium, okay? Hey, there's a lot of questions on that. So making sure you understand the signs and symptoms that go along with it. And what do we expect? And this is one that comes up a couple of times. So the causes of neuromuscular excitability, what causes that to increase? So when you're going through this, and there are charts that go along with this, there are a few that meet that criteria, but know which few they are and know which elements are associated. And I don't know why right now I'm staring at this thinking, did I say this correctly? I'm pretty positive I did, but just in case I didn't, kalemia is potassium. Hopefully I said that. I don't know why I'm doubting myself right this second. Okay, symptoms of clinical dehydration. This is going to be a select all, so be ready for that. Okay, what are some abnormal routes for fluid loss? So there are routes that we normally lose fluids throughout the day, throughout life, okay, as we metabolize. But what are some abnormal routes? And what are two major causes or categories, not causes, of fluid imbalances? All right. Now, chapter 25. And I am at the end of this, in this announcement where you see the guidance, the week 4 instructions within Canvas. I'm going to put this video link because it is a great, quick breakdown of the difference between metabolic acidosis and alkalosis and respiratory acidosis and alkalosis. Okay, so I'm saying that and I'm trying to emphasize it because I think a lot of students get confused. When we meet later this week, I'm going to show some diagrams. You can easily Google some diagrams that represent the characteristic signs and symptoms of respiratory acidosis and alkalosis versus metabolic acidosis and alkalosis. But be familiar, because if you don't understand the difference, then it's going to be very difficult to be able to choose the correct answers that go along with it. So before we even get into everything, I want you to understand the concept of your body compensating for something versus your body correcting it, trying to correct it. So compensation versus correction. All right. Then I bring in the metabolic. So relationship between metabolic alkalosis and hypokalemia. Okay. Common causes of respiratory alkalosis. Notice how I went from metabolic alkalosis to respiratory. They are totally different. Totally different. Do not think they're the same thing. Okay. Early signs of metabolic acidosis. So previous question up here was alkalosis, and here we're talking acidosis. Renal compensation versus renal correction. So remember, renal means kidney. I'm just going to give you a quick heads up that this has to do with metabolic alkalosis and acidosis, which is also right underneath it, why I say respiratory compensation and respiratory correction, because that has to do with respiratory acidosis and alkalosis, so the lungs. Then right here, this section, and I'm going to kind of take it in one bit, using these terms that I want you to watch this video link that I put in there. But using these terms, if you can answer these questions and fill in the blank, it'll benefit you. It helps you to analyze the content. So respiratory response to an increased blood pH is what? How does the respiratory system respond to increased blood pH? The respiratory response to decreased blood pH is what? All right. If a person hyperventilates, carbonic acid will what in the blood? And this is not one of these answers, but you can increase or decrease, obviously would be, I don't want to say obvious because that's rude, but you understand what I'm saying. So, but anyways, they're trying to explain these different conditions here and trying to get you to be able to analyze how is respiratory and metabolic acidosis and alkalosis, how are they different, and how does the body correct it? Okay. So, I believe that's it for week 4. I will also be releasing a week 6 signature assignment video here in a little bit, but good luck, study hard, keep grinding, and I'll talk to you the next time.